patients having high SUPAR levels, SUPAR is a sepsis marker, anti-interleukin-1 can have a beneficial effect. But we could have tested many other things, and I have no time to discuss all this, but clearly we could have done a better job, especially if we had not spent so much time with hydroxychloroquine. We could speak about purification techniques and the pro and con, and they have been approved by the authorities because they do make sense. But in terms of other treatments, we still have the camostat, nafamostat running. We could have recombinant ACE2. We could have estrogens. We know that women had a better outcome than men. Maybe giving female hormones could be good, and there is a good rationale for this. And there are other agents that we could have tested, and unfortunately, we have not had the chance to do it well enough. Hopefully, the platforms from the UK, from Europe, from the US, in part, could actually help to find some therapies, but there is much more to do. So this international collaboration, I think, will remain. And these platform trials will still be used for other strategies in the acutely ill patient, in the emergency room, in the intensive care unit. So the future is clearly towards better patient identification and perhaps adaptive designs that we are now using in the field of COVID and that we will continue to use in other diseases. There's some interesting stuff about genetic factors, but I need to move on to emphasize that even though COVID-19 is a single disease, we need to individualize our therapies. When to intubate the trachea has been a big, big issue, because if you do it too early, there may be some alterations in the lungs and risk of nosocomial infection. If we do it too late, there is a risk of respiratory arrest. We understood that in the lungs, it's not only RDS. Gattinoni proposed to speak about respiratory failure type 1 and type 2. We argue that the RDS is just a syndrome. So you can call it RDS or not, it will not really affect very much the outcome. Hemodynamic management has been largely neglected because many people gave diuretics when they saw the chest x-ray. But these patients very often had some degree of hypovolemia associated with the acute disease. And it took months to realize that we should stop giving diuretics early, but rather consider fluid challenges and consider administration of the butamine when there is some myocardial depression. And we and others showed that there may be pulmonary embolism that require appropriate therapy. And finally, there may be a distributive defect associated with sepsis. The last thing is, for the last minute, because I think I am over time, prioritization. Of course, in usual times, we can already lack ICU beds. But when there is a surge like this, of course, it creates ethical dilemmas. We should always use adapted therapy, proportionality of care. We should not start mechanical ventilation in elderly patients, in patients with severe comorbidities. No way. I like this sentence from the lay press of a woman, 90, dies from coronavirus in Belgium after refusing a ventilator and telling doctors, I had a good life, keep this for the younger. And from the beginning, I argued that we will face the problem. Even if we can expand the number of beds, we will not have enough facilities for everybody. So that's what we call distributive justice. And in this context, we need to have appropriate triage. And even with appropriate triage, we need to consider that the ICU is never totally full. Never! Because otherwise it will be the rule of the first come, first served. People arriving earlier would have better chances, and this is clearly unacceptable. So we need to revisit the occupation of the intensive care units and make actually sometimes some difficult choices. And the rule of lottery has absolutely no application either. It's not two patients for one bed. It's much more complicated than that. So finally, the psychological support. We learned the importance of team decisions. And of course, there are many decisions to be made. Why would patients die of COVID-19? That's the question I raised in the Lancet here, saying, you know, we can start mechanical ventilation. Doesn't work, we could start ECMO. It doesn't work with VV ECMO, we go to VA ECMO. Why would patients die? Sometimes we cannot start ECMO because the use of ECMO here may prevent appropriate care for the next patient. So that's not actually acceptable. So all of these are very difficult choices, and who dies of COVID-19 is actually a difficult question, because patients may be at the end of their life when they develop COVID-19, and so I invited people to define what the exact cause of death is. Is it really COVID-19, or is it the underlying disease? And all of this needed psychological support for the families, for the patients. I like this little thing in Texas of doctors who put their picture on their chest so that the patients could really see their face. And in some places there was some music in the ICU, but we also needed some help for the team. Remember this emergency doctor who committed suicide after a terrible night in New York City. So we learned more about this as well. We learned so many things, and at the end, we can really be proud of what we have accomplished. We have made progress, and we have seen that in previous talks, and I think I have to stop here, so thank you very much.
Thank you. Thank you, Professor Vincent, for this nice presentation and very illustrative. Unfortunately, we have no time for questions, and we have to move forward. We are going to try now to do our Zoom connection with Sagar Galbankar, that is going to talk us about the World Network to respond to COVID. Let us try the connection. This is we are trying the Zoom connection with Professor Sagar. If there is no connection, we can move to the next speaker. Yeah, so we move to the next speaker. Next speaker is Oleg Sekera from Ukraine. Oleg or Anton. Anton, are you going to do the presentation? Yeah, so then the floor is yours. The speaker is different. Anton Bolesovets from Ukraine is going to illustrate us about the features of medical care during the COVID-19 pandemic in Ukraine.
Thank you very much, dear colleagues. First of all, good day, dear friends. I would like to express my deep gratitude for our organizations and personally ourselves, me and Professor Sekera, to Emergency Physicians Association of Turkey and Professor Basar Cander for wonderful opportunity to share our experience, gain new knowledge, and meet new friends. We all knew what COVID-19 is. It is obvious that someone will call it a virus, and they will be correct. Someone would call it a catastrophe, something like a catastrophic pandemic problem, and they also will be correct. But I would like to say that COVID-19 is more than this problem. It is rather like a war. More to say, it's a third world war. But because only problems so hard and so complex could unite all nations throughout the world and defeat it. We all holding hope for the better. We are trying to believe the promises of WHO. We are all trying to inspire the fickle flame of hope in our hearts. But hope relies for now for vaccination and collective immunity. Plus, I would like to add here a third element. It is virus itself. Because when it becomes less lethal, less deadly, less spreading, only then we will be able to defeat it. For sure, you are a bit tired from all of dry statistics, different maybe factual information. So, if you don't mind, I would like to tell you a tale. A tale about ignorance, heroism, and hope. A tale of COVID-19 in Ukraine. You see those numbers on this presentation, and let me assure you, they are all lies, because they were truth only when we created this presentation, and for now, our situation is much more dire, much more grave. When I left the country, it was yellow zone. We all knew that any possible divisions of level of danger goes like green is good, red is bad. But we must admit that these levels could not save us from spreading of disease. So, let me start from element of ignorance. Ignorance of our government, ignorance of our doctors, and ignorance of our common people. We did not know how to treat COVID. We did not know how to protect ourselves. That's why we were afraid. The fear gave the birth to the war criminals, disinformation spreaders, and our efforts to fight the ignorance and disinformation were quite futile. We are trying to create different infographics. We are trying to speak with people, speak with our patients, but their fear clouded their minds. The second part, which I'd like to tell about, is a part of a heroism of our doctors. First of all, I'd like to say that the burden, great disadvantage, and great danger for our doctors is a very serious and very grave situation. Our doctors were poorly protected, poorly paid, poorly respected by those whom they save. But nevertheless, they help people. They saved lives. They sacrificed their own lives. Nearly of 20% of our doctors, 20% of casualties from COVID in Ukraine were doctors. We're trying to protect ourselves. We're trying to hardly work for this help for the people. But nevertheless, this hope was not enough. To be honest, I'd like to pass some slides, and I'd like to come to the third element. Yes, this is a war chronics for us. This is the photos of our doctors. Some of them are not alive right now. And you may see that the statistics for the death of the doctors is quite dire. The third element of my tale is hope. For now, we're placing our hope for the vaccines. We have a lot of them right now in Ukraine. We have enough of them. But we do not have faith in them, which makes our efforts quite futile. We have a plan of vaccination. It includes different stages which allow us to help our people, to protect them, and give a possibility of vaccination to all of our population. But the main problem is those war criminals, those distrust, those fear. People do not understand the way vaccines work. People do not understand how they will help them. And it is a main problem. That's why, for now, a great part of our hope relies on cooperation, on mutual help and learning, on sharing knowledge and experience. And I feel a deep gratitude to Professor Basar Jander for inspiring that hope. There is a famous sentence: united we stand, divided we fall. Let us unite our efforts, our knowledge, our power, and if we do so, we will win this war. We will prevail. Thank you.
Thank you. Do you have any questions? I've got one. How is the situation now in Ukraine, in your country?
For now, we have quite dire situation because when we left a country, it was nearly of 2 millions infected in general. For now, it's 2.5 million in general. Plus, every day we have grown statistics in case of illness of COVID. It is like 40, 80,000 per day, 400 deaths per day. It despises the level of vaccination because for now we have only 15% of our population vaccinated. We're putting great effort to vaccinate our doctors, our policemen, all people on whom society relies, whom are needed for functionality of society, on poorly protected people, on vulnerable people like elder people, yes? But for now, our vaccination is backstaged a bit because of this enemy, because of this ignorance. People are afraid, and we're trying to relieve them from this ignorance. We're trying to educate them, but this is a long-term war.
Thank you. Do you have any questions? So thank you so much. We're moving for the next speaker via Zoom. We hope that we will have our colleague for the Zoom conference. We try to join our colleague. Hello, hello, yeah. It's ready, good. You introduce. So on the Zoom, it's the World Network to respond to COVID. So Dr. Galwan Nakar, you are on the line. We can not see you for the now. It should be coming in a few minutes, in a few seconds. Can you hear us?
Yes, I can hear you.
Great, great. You have 15 minutes. It's your time. Thank you.
Very much. Can I share my screen, please? Is my screen visible? Is the screen visible?
Yes, it's okay. You can go.
Good evening, everybody from our friends in Turkey, and this is morning in America. I wish I could be there with you all, but you know, COVID has put a lot of restrictions on us. I'm very thankful to EPAT to invite me, and I eagerly look forward to this meeting every year. We have been in close touch with the EPAT team as we develop the COVID protocols to the World Academic Council of Emergency Medicine. My talk for today is the World Academic Council of Emergency Medicine's response to COVID-19 and how did we respond to it. My disclosure, I am the Executive Director of the World Council. I'm also Associate Professor at the Florida State University Emergency Medicine Residency Program. I head the Director of Research in Emergency Medicine, and I'm a staff physician at the hospital. I have no other commercial affiliations. My talk begins with bringing to you all the greetings from the members of the World Academic Council of Emergency Medicine, which brings together academicians across the world to innovate in emergency medicine. I call it a melting pot for innovation. It's a coalition of academicians and academic institutions. It's totally apolitical. It focuses on emergency sciences. It was founded in 2015. It holds the annual World Congress of Emergency Medicine. The 2018 meeting was held in Qatar. 2019 was in Dubai. Last year, we did it virtually. We focus on patient-centered education, patient-centered research, and patient-centered clinical care. Our focus is also to churn out science, which becomes knowledge. Hence, we do a lot of publications and we promote academics and academicians and academic institutions 24/7. The framework is emergency sciences for the World Council. Hence, it's emergency medicine, trauma, acute medicine, critical care, injury prevention, public health policy. And we work with students, residents, physicians, paramedics, nurses, and policy makers. So it's a complete compendium of the science of emergencies. What did we do when COVID struck? So it's been going on for 2 years, our response. It revolved around the 4 fundamentals of I. That means it's all on us. One was interaction. We brought leaders together. Innovation. We created protocols and models of care. We disseminated information. And we integrated technology and process management into the development of our protocols. This is our blog address. For the last 83 weeks, non-stop, every Saturday, the experts from around the world meet at 8 p.m. US time, so across the world, including EPAC. Till date, we have had over 5,000 attendees. And this has led to landmark publications, which have won a lot of recognition across the world. Our COVID primer was published way back when the COVID pandemic struck. It is a 42-page document with experts around the world for all data concerned with COVID, its science, its response, its pathology. It was the only primer ever published with a complete information in over 200 references in COVID-19. That was our first publication. Then we focused on the patient journey. So when a COVID patient comes to the emergency department, it has to get triaged. It has to be cared in the emergency department, and then it has to be disposed either to ICU, to the floor, or home. So we tackled each problem with a collective wisdom across the world. And we came up with the silent hypoxia algorithm as to how in the triage would you demonstrate silent hypoxia. This algorithm was developed after intense meetings, our Saturday conferences, which deals to the evaluation of silent hypoxia and the triage. Next was coming up with the ventilator sparing protocol. As we all know, initially, everybody was being put on a ventilator, and we needed to come up with a ventilator sparing protocol. This protocol was used in the state of Kerala in India, and it won the award for the minister. We did huge training programs based on these protocols, and it was called the ventilator sparing protocol. It was step-by-step approach, and it was appreciated across the world. Every step on how do you tackle hypoxia and which patients would really need the ventilator. So unnecessary ventilation could be avoided. It was published in the International Journal of Critical Illness and Injury Science. The third most important paper was how do you tackle patients with hypoxia who you send home on oxygen? Very unique situation. Home monitoring system of hypoxic patients who go with pulse oximeters or home oxygen. How do you tackle that? We came up with that protocol, which was published in the Journal of Family Medicine and Primary Care. These papers are all in PubMed. This pandemic gave rise to telemedicine and the whole system of using telemedicine very cleverly. But telemedicine is not just opening a video and talking. There are a lot of framework issues in telemedicine when you have to incorporate it in a patient-doctor interface. And if telemedicine is going to become a culture, then it has to be incorporated around a particular pillar in a particular model via a particular process. It just cannot be a video audio conversation. And then when we started thinking about the science of telemedicine, we published our first paper way back in 2020. And last week, our landmark paper with the World Health Organization came out on the framework of using telemedicine technology at healthcare institutions. It's again available on PubMed. It'll soon be, it's just 2 weeks ago. You can get the full article on how do you incorporate telemedicine into healthcare institutions as a culture of telemedicine. Right now, we are using telemedicine as a crisis telemedicine. We need it, so we use it. But how do you make it a culture? And there's a framework for that. As we know, we are battling or waiting for the third wave, when it's anticipated that pediatric patients will be the most affected. Recently, I had a lot of deaths in India, so we were called upon by the WHO Collaborating Center to come up with a preparedness toolkit, which we prepared, which was published. And it's a very exhaustive toolkit on how to equip and be ready for COVID-19 when it comes to pediatric patients. This paper was appreciated across the world. This was made to the front cover of this landmark journal called Shock, where the World Council experts discussed the creation of the COVID flu model, combining the COVID and the flu together and mapping the immunological pathways, which led for us to recommend strongly that the COVID vaccine and the flu vaccine should be given simultaneously. Both complement each other. So you cannot leave out the flu vaccine. An aggressive flu vaccination program should be a part of the COVID vaccine strategy. And this was appreciated and accepted. And in fact, it's become common practice in the US now. Across the world, we saw the collapse of the supply chains. The supply chains for PPE, the supply chains for ventilator collapsed. We are living in an era where we need to biosecure these supply chains. Our landmark paper on the supply chain management, which could restart the economy of COVID, was also published through this group, which was downloaded many, many times. Again, it's available on open access. We discussed about how the impact and what recommendations we could do to decrease the supply chain. One of the most important papers after the COVID primer was our blind spots paper. It really brought to light all the challenges we faced in handling this COVID pandemic. Where did we fail? What happened? And what could have been avoided? And what lessons could we learn from our blunders? Beautiful paper. We worked on it for nearly 3 months and it was published. It was the American College of Academic International Medicine, which collaborated with the World Council to come up with this paper. Another recent paper which came out 2 days ago in the Western Journal of Emergency Medicine is our EMERGE Network, our Emergency Medicine Research Network paper led by Mahajan, where we discussed about the responses of emergency departments across the world. So what you have seen in the last few slides is our concentrated effort to bring experts together to not only tackle the basic science aspects of immunology, but also the triage situation, the ventilator sparing algorithm, the discharge situation, the blind spots, that means the failures, and also the complete information about COVID, and using also a focus on technology of telemedicine. So here, as a World Council, we focus on all the major areas, and our collective wisdom of brilliant people is what sets us apart. We led to the creation of this model called improvised patient care journey, where we flag it a patient in the triage. We have a goal-directed care towards the patient, and we have disposition, which is vigilant. That means we follow our patient, and it's policy-driven. Who can be admitted, who can be discharged, who goes on the ventilator. So in the end, what WASM delivered was translation and transformation, whether it was basic science, clinical medicine, public health, leadership, collaboration. We continue to do our education by our Saturday meetings. We continue to do our research at our centers. We improvised patient care with our algorithm. We incorporated the telemedicine technology, and we professed quality practices, keeping in mind that we respected the academic sovereignty of nations. So every nation responded separately. We didn't call anybody out. We included age, gender, specialty, students, health workers, physicians, administrators. Everybody welcome to our meeting. and we do these meetings every Saturday. As I speak, a new variant of COVID is taking shape, and we should be worried. Every new variant comes with new challenges. I invite you all to WASM 2021, which will again be held virtually, but this time hosted by India, as India celebrates 75 years of independence. As you can see, it's also being endorsed by the WHO Collaborating Center. And it will be held from 10th to the 19th of December. I invite you all to submit abstracts, attend, or even speak at our meeting. If you can go to our website, will be up in this week, and you could be a speaker there. I thank my very good friend and my co-founder of the World Academic Council of Emergency Medicine, Professor Bashar, who continuously works with us on these scientific algorithms, a very focused leader and a very magnanimous leader indeed, who bridges gaps and builds networks. I thank you all at EPAD for giving me this opportunity. I wish I could have been there with you all, but maybe next year we'll be there. And I invite you all to WASM 21 in December virtually. Thank you very, very much. This is my email and my Twitter handle.
Thank you, Dr. Galvankar, for your presentation and for being on time. I think we have at least time for one question, and I know that my colleague Eric has prepared a question for you.
Do we have a word question? I just one. Can you hear me?
Yes, sir.
Yeah, just a question about the role of telemedicine. Did you use telemedicine a lot, and what kind of patients do you think are the better for the use of telemedicine?
Fantastic question. Telemedicine, sir, if you look at the concept of telemedicine, telemedicine in COVID has been like a leapfrog. We never used telemedicine. We always liked the patient-physician contact. But in COVID, what happened was crisis telemedicine. That means we had to use telemedicine. Everything was shut down. But now when we transmigrate from the crisis telemedicine, culture telemedicine, there's a huge focus on how do we really make it a culture. That means it has to have the pillars of accountability, maintenance of patient data. How far can we go for in telemedicine? Can we do examination? Can we do just a visual? What is allowed? What is not allowed? What judgments can we make just on a telemedicine exam? What is a first encounter exam? What is a follow-up exam? What is an assessment exam? Different strategies, different models, and the pillars of accountability. Is that patient data recordable? Is there going to be digital data also along with the audiovisual data? How are we going to assess the speed at which we see those patients? How do we assess quality? How do you do quality control when you use telemedicine? So these are the huge frameworks which we have to, and patient confidentiality, because again, it's audiovisual record, are to be used. So we use telemedicine, but now, apart from use, the scientific academic community is more focused on evolving this around a framework which is quantifiable and improvisable. So that's where the academic focus is now.
Thank you. Thank you for your answer. Now it's time to move to the next speaker. I have the pleasure to introduce Dr. William Halakoglu, that he's going to report about the situation in the United States. Please, the floor is yours.
Good afternoon, or should I say good evening. İyi akşamlar. İsmim Birol Halaçoğlu. 14 yaşında Amerika'ya gittim. Orada acil bölümünde doktorluk yapıyorum. Amerikalıların Birol Halaçoğlu demesi çok zor olduğu için bana Bill demeye başladılar. Bill de William'ın kısası olduğu için o takıldı gitti. Aslında ismim Birol Halaçoğlu, %100 Türk. I was asked to give an update in the United States on COVID cases. I practice in 2 states in the U.S. My main practice is in Detroit, Michigan, which is a state in the north section of the country. I also practice in Las Vegas, in Nevada, which I'm sure you all know about. You've been to Las Vegas probably at one point or want to. If you haven't, I would definitely recommend visiting it at least once for ASAP, if nothing else. These statistics were taken from CDC website, and they're up to date as of October 14th. There's been 44.8 million cases in the US, and about 723,000 people have died. I'm sure that number is probably increasing by the day. The states with the most common infections are California, Texas, Florida, New York, and Illinois. Most of the bigger cities are in those states, and Florida has a large number of retirees, older people, and they tend to be more infected. Worldwide, there's been about 220 million people and about close to 5 million deaths in this as of October 14th. As far as vaccinations go, United States is very active in vaccination, making progress every day. At least 218 million people have received at least one dose. That's 65% of the US population as of yesterday. And fully vaccinated people are about 188 million, 56% of the population. And these vaccines are administered to all citizens above the age of 12 years old. Ages 18 and higher, 176 million people have been vaccinated. Elderly over the age of 65, 46 million fully vaccinated, and that's about 85% of our population for 65 and older. And 8.9 million, as of yesterday, have received booster vaccination, which is a third vaccination of Pfizer. Also, FDA approved Moderna. I don't know if Moderna is available in Turkey or not, but Moderna is probably as popular as Pfizer vaccine, BioNTech vaccine in US. And yesterday they approved half dose as a third dose, but it has to go through a couple more procedures before it can be administered. As you can see, we're getting close to herd immunity, which is usually 70% of the population either vaccinated or have had contact with the disease. Our experience shows that the vaccine is very effective against variants of COVID. Studies in the United Kingdom and South Africa shows 97% effectiveness against alpha and beta variants for severe illness and death, and 88% for Delta, and that came from India. Inactivated Chinese vaccine, CoronaVac, was only approximately 50%. So even though we're making progress with the vaccine, there's still a lot of questions that we need to answer. How long will the immunity last with these vaccines? And what's the role of the third vaccine? Is it really necessary or not? These are questions to be answered probably in the next few years. There's also questions that come up about pregnancy and lactating women and children, whether vaccination is safe or not. Pregnancy and lactation, COVID increases the risk of maternal and perinatal morbidity and mortality by quite a bit. And COVID study shows that pregnant women in 18 countries had increased risk of preeclampsia, ICU admissions, and maternal mortality. And babies were also affected by preterm labor and perinatal mortality during birth. Pregnant women generate actually a better immunity when they receive the vaccine than the natural cause. And they appear to be safe in pregnancy so far, although data is pretty limited on this. Vaccine adverse reaction studies show that data appears to be consistent with general population, 86.1% live birth, 13.9% pregnancy loss, and 9.4% preterm birth. And that's same as the general population. Formal guidelines for pregnancy, American College of Obstetricians and Gynecologists recommends that pregnant individuals have access to the vaccine. CDC also recommends pregnant patients to receive COVID vaccine. Also for lactating individuals and it should be administered to lactating individuals just as non-lactating females. There's a lot of myths about vaccines in the US. I'm sure the situation is the same all over the world. One of them is vaccines alter your DNA, so people don't want to get it. But the fact is that mRNA vaccine do not alter DNA. It only penetrates through the wall of the cell. It never goes to the nucleus. And the DNA vaccine from J&J enters the nucleus, but it doesn't change the DNA genome. There's also a myth about a protein spike. I don't really know what it is. I never understood it. Some people ask me about protein spike being bad for you. You can get a protein spike from a protein shake, so I'm not sure what the controversy is on that. And vaccines are not made from aborted fetal tissue. Higher antibody levels actually come from vaccination than natural infection. One thing is clear, that COVID vaccination is the most effective therapy we have right now, so I would encourage everyone to emphasize to your patients that vaccination is good. I know there's a shortage of vaccine in Turkey, but when it does become available, people reject it. Please emphasize how important it is to get vaccinated. It's been proven to be effective for death and serious hospitalization. And I thank every one of you for fighting COVID in Turkey. I do have a couple of comments to make. As you know, when COVID came out, everyone was surprised by it, and we actually didn't know what to do. Last year, when COVID hit US between March and July, we had so many cases that we really didn't know how to treat. And I intubated several patients in ER and never went to ICU. They ended up dying in our department. But when the second wave came last May, June, I think we learned a lot and we did a much better job. First thing we did was patients that we ruled out serious illness by doing either CAT scan of their lungs and doing other tests. We set them up with home oxygen. If their pulse ox was less than 94% and higher than 88%, we put them on 2 liters of oxygen. We had 2 companies we contracted. They actually came, they sent representatives to the hospital emergency department. They set them up with oxygen, and we sent them home with a pulse ox, and they received oxygen by this company every day. Of course, the insurance company paid for it. We kept them out of the hospital, and majority of those patients did well on their own. Some of the higher risk patients, we gave monoclonal antibody infusions and did the same thing, and they did well also. High risk patients that have COPD or heart problems. Our goal was to keep them out of the hospital and treat them at home, and that really worked. We still have COVID cases, but as of yesterday, I practiced in a 70,000 volume ER, and our ICU only had 1 COVID patient yesterday, about 9 COVID patients total. So we're making progress treating COVID patients and keeping them out of the hospital. But the problem we have right now is we still have a lot of patients in the ER that are waiting for a bed because we don't have enough nurses. Healthcare workers in the US either quit or they were laid off when the patient volumes went down in the hospital. So the biggest problem right now we're facing is actually lack of employees, nurses, phlebotomists, radiology technicians. Some of them are refusing to come back. Others have found other jobs. And we have 350 beds in our hospital, and 2 floors are closed because we don't have enough nurses to care for the patients. So that's one of the problems we have after related to COVID. But hopefully that'll be resolved soon. And hopefully with vaccination and the treatment that are coming around, we'll get over this. Thank you.
Thank you. Do we have the time for a quick question? Because we are...
Türkçe'de sorabilirsiniz.
no question. So I would like just to end with Luis Castrillo. He has some words to say about the COVID situation.
Thank you, Eric. It's going to be very short. It is just because we are ending this series of COVID presentations, and I don't want to end this without having a thought for all our colleagues that have been taking care of us. Unfortunately, some of them, they passed by. They have been suffering, not only them, also their families. So let us keep them in our memories and our respect for all of them. Thank you for this. The session is over. Thank you, all of you, the speakers especially, and those who have been attending to these very interesting presentations. Thank you again.
Oturumunda ben de iki atisistokompleks desteğinin COVID-19 hastalarında etkinliği üzerine yaptığımız bir çalışmadan bahsetmek istiyorum sizlere. Atatürk Üniversitesi Acil Tıp Anabilim Dalı'nda öğretim üyesi olarak çalışmaktayım. İlk olarak başlığımızda da adı geçen iki atisistokompleks nedir? İlk olarak ben bunu anlatmak, bunun ne olduğunu tanıtmak istiyorum. İki atisistokompleks adı üzerine bir kompleks. Burada 4 tane maddeden bahsedeceğiz. Bu maddelerin çeşitli oranlarla elde edilmiş bir karışımı. İki atisistokompleks içerisinde ilk tanıtacağımız preparat kuşburnu ekstratı. Bildiğimiz bir ürün, ülkemizde her yerde hemen hemen yetişen bir ürün. Şimdi bu kuşburnunun özelliği bizim için gülgiller familyasından yüksek düzeyde C vitamini içermesi bizim için önemli. Ek olarak B ve E vitamini içermekle beraber asıl etkinliğini yüksek düzeydeki C vitamininden almakta. Ek olarak doğal şekerler, organik asitler, çoklu doymamış yağ asitleri, fenolikler ve uçucu yağ bulunmaktadır. Bu kuşburnu esansiyel yağ olarak da alkol, monoterpen ve seskiterpenlerden oluşmaktadır. İkinci ürünümüz ise kara bamya çiçeği ekstratı. Bu hibiscus sapta diye Latince isimlendiriliyor. Hibiscus dediğimiz zaman zaten aklımızda bir şey uyanıyor zaten. Bu hibiscus bizim ekranda gördüğünüz ürünümüz. Aslında çiçeği bu şekilde, meyvesi de bu şekilde. Hibiscus'la ilgili ülkemizde bir nar çiçeğiyle ilgili bir benzetme var. Bu bir nar çiçeği değil. Yani ülkemizde yetişen bir nar çiçeği değil. Bu bitki genel olarak Batı Afrika'ya özgü bir bitki. Ülkemizde nar çiçeğiyle karıştırılmakta ama aslında bir ilgisi ve alakası bulunmamaktadır. Hibiscus doğal gıda renklendiricisi olarak kullanılmakta. Ülkemizde ise bu preparat genellikle bamya çiçeği olarak bilinmekte ve birçok çay çeşitlerinde, çayların içerisinde bulunmakta. Özellikle bu piyasada satılan bitkisel çaylarda renk vermesi için kullanılan bir preparat. Bamya çiçeği olarak ben baktığım zaman birkaç firmada gördüm bunu. Bitki çaylarına demlendiğinde kırmızı renk vermek için kullanılıyor. Ama bu bildiğimiz bamya değil arkadaşlar, hibiscus. Hibiscus'a baktığımız zaman ise PubMed'de 1500 tane çalışması var. Aslında hibiscus da ciddi bir potansiyele sahip, genel bir bitkisel ürünlerde olduğu gibi. Çünkü özellikle antosiyonu ve polisakkarit ve organik asitler gibi fitokimyasallar açısından zengin bir bitki. Özellikle hipertansiyon, hiperlipidemi, obezite, kanser, kronik karaciğer, böbrek rahatsızlıklarında ve özellikle dejeneratif ve enflamatuar hastalıklarda kullanılmış. Bizim için önemli olan kısmı ise antibakteriyel ve antiviral etkinlik gösterilmiş bir ürün. Diğer ürünü içerisinde bulunan diğer ürünümüz ise sater ekstratı. Bu karabaş kekik, kara kekik, sater, zater, zahter isimleriyle bilinen kekik. Bu kekik su buharı ile damıtıldığı zaman elde edilen kısmına kekik yağı, altta kalan kısmına ise kekik suyu deniyormuş. Bu kekik yağı aktif olarak kullanılıyor. Bu kekik yağının içerisindeki aktif ürünümüz ise karvakrol. Yani kekik yağının içerisinde karvakrol, gamma terpinel, PSMN ve timol bulunuyor ama asıl bizim için etkinliği olan bu preparata katkısı karvakrol üzerinde. Karvakrolla ilgili de gördüğünüz üzere 2200 tane çalışma var. Son dönemlerde birçok etkinliği kanıtlanmış ve özellikle yine son yıllardaki çalışmasının artmasını göstermek istiyorum. Bu ülkemizde yani yurt dışından birçok çalışma olmasına rağmen burada kaymış bu Tarım ve Gıda Bakanlığı'nın şu ekranın sol tarafında gördüğünüz Tarım ve Gıda Bakanlığı'nın bir yayını var bununla ilgili. Ülkemizde de çok miktarda yetiştiği için özellikle bu zahter Güneydoğu'da daha çok kullanıldığı için de birçok preparatta yani günlük yaşamda kullanıldığı için Gıda ve Tarım Bakanlığı bunu onaylamış kullanımını. Burada antibakteri etkisinden bahsediyor. Soldaki slide bir şekilde kaymış, onu gösteremedim size. Bitki özütlerinin DNA koruyuculuğu aktivitelerinde ve Stenofonomas maltofilden üzerindeki antimikrobiyal etkisi var. Ülkemizde çok fazla miktarda bununla ilgili çalışma yapılmış. Çok fazla bizim bildiğimiz, bizim kullandığımız, bize biraz daha baktığımız zaman özgü bir bitki diyebiliriz. Çok zamanda herkesin evinde kullandığı bir ürün. Kudaba ekstratı Helicerium ailesinden ismimiz biraz söylemesi zor olduğu için ölmez çiçeği olarak isimlendireceğiz bundan sonra. Ölmez çiçeği. Ölmez çiçeği de ülkemizde yetişebilen ve bahçelerimizde daha çok yani yazda, doğada görebildiğimiz bir bitki. Buna baktığımız zaman ölmez çiçeğinin içinde birçok madde var ama asıl etki bizim bu preparatta geçen kuarsetin. Özellikle Covid-19'dan sonra çok sayıda tanısı oldu, çok sayıda bilinmeye başladı. Bu Helicerium dediğimiz zaman 316 makale çıkarken kuarsetin dediğimiz zaman 21.900. Şu an muhtemelen bu 22.000 olmuştur. Yine buradaki tarihlere dikkat çekmek istiyorum. 2022'de ne kadar çoğaldığını, ne kadar arttığını. Kuarsetin madde olarak Covid-19 ile bizim hayatımıza girdi. Birçok yerde kullanımı var. Daha önceden de defalarca kez başka alanlarda çalışılmış. Kuarsetinin mucize molekül olarak değerlendiriliyor. Çok ciddi bir immün modülatör. Bununla ilgili diyabet, tansiyon, kanser hastaları üzerinde ciddi bir çalışmaları var. Covid-19 ile beraber antiviral etkinliği kanıtlandı. Ve en son çok ilgimi çeken bir çalışma olarak analjezik etkinliği üzerinde de bir çalışması var kuarsetinin. Biz de geri çalışmamıza dönecek olursak 2-atisito kompleks nedir? 2-atisito kompleks bu size anlattığım moleküllerden oluşan bir kompleksi verilmiş bir isim. Görüldüğü üzere belli oranlarda karıştırılmasıyla elde ediliyor bu. Mililitresindeki 3.42 gram gibi. Buradaki işte karabamya çiçeği 3.14 gram gibi mililitresinde saflaştırılarak elde ediliyor. 2-atisito kompleks patentli bir ürün. Takviye edici gıda olarak onayı vardır Gıda ve Tarım Bakanlığı'ndan. 10 mg içerisinde 3000 mikrogram 2-atisito kompleks bulunmakta. Kullanım şekli ise 3x2 ölçek şeklindedir. 2-atisito kompleks ile ilk bizim tanışmamız COVID-19 hastalarında böyle bir molekülün olduğunu ve bunun COVID-19 hastalarında kullanılabilir mi diye bir yola çıktık ve makale olarak yayınlanan bir klinik olarak ispatlanmış etkinliğini sunmak istiyoruz. Yola çıkarken dediğimiz gibi 2-atisito kompleks şurubun COVID-19 hastalıklarında takip edilen klinik, laboratuvar ve PCR negatif süresi üzerinde etkinliğini test etmeyi amaçladık. Tek merkezli, prospektif, randomize kontrollü bir çalışma. Bu COVID-19 PCR pozitif tanısı alan sağlık personelleri çalışmaya dahil edilmiştir. Çalışmamızın da etik onayı Atatürk Üniversitesi'nden alınmıştır. Çalışmamızda Eylül 2020 ve Eylül ve Aralık 2020 tarihler arasında enfeksiyon hastalıkları polikliniğinden alınan PCR testi pozitif çıkan 150 hasta çalışmamıza dahil edilmişti. Bu 150 hasta tamamen sağlık çalışanlarının oluşmakta idi. Çünkü o dönemdeki ulusal rehberimiz ancak buna el veriyordu. Çünkü 7 gün sonrasında bir PCR testi normal halktan alınmıyordu. O yüzden 7 gün sonra sağlık çalışanları eğer PCR testi negatif ise işlerine dönebiliyordu. O yüzden çalışmamızı dizayn ederken sağlık çalışanlarını aldık. 75 hastaya o zamanki Sağlık Bakanlığı'nın uyguladığı rehber doğrultusunda tedavi planlarken diğer 75 hastaya ise 2-atisito kompleks tedavisi eklendi. Uygun bir şekilde bilgisayar programıyla kime ne verileceği randomize edildikten sonra. Hastaların laboratuvar parametreleri, klinik seyri ve PCR'ın negatifleştiği ilk günler karşılaştırıldı. Çalışmamızda daha önceden bilinen bir komorbiditesi olan oda havasında arter kan gazında PO2 bölü FiO2 oranı 300'ün altında olan hastalar ve 2-atisilo kompleks içeriğinde herhangi bir alerjisi bulunan hastalar dahil edilmedi. Sonuçlara bakacak olursak her iki grubunda aldığımız hastalardaki yaş ortalamamız benzer. 2-atisilo komplekste 30 iken kontrol grubunda 29. Hastalar %53'ü 2-atisilo kompleks grubunda %53'ü erkek iken kontrol grubumuzda %57. Bu da çalışmamızda yaş ve gruplar arasında bir istatistiksel bir fark olmadığını göstermekte. Bizim asıl çalışmamızla ilgili vermek istediğimiz tablomuz burası. Şimdi bu tablomuzla ilgili özellikle birkaç tane noktamız var. Özellikle lenfosit sayısı. Lenfosit sayısında anlamlı bir şekilde 5. günde kontrol kanları alındığı zaman anlamlı bir şekilde yükseldiğini, başvuru anında 815 iken bunun 1238'e yükseldiğini, kontrol grubunda ise benzer 785'e 938 olarak benzer kaldığını görmekteyiz. Lenfosit sayısında anlamlı bir artışı var ve asıl bizim açımızdan önemli olan tespitlerimiz SRP, D-dimer ve ferritin. Neden bunlar önemli? Bu dönemde bizim COVID dönemine daha çok hayatımıza giren sitokin fırtınasına doğru bir gidiş anlamı taşıyor. SRP'leri 38'lerden 5. gün 10'lara düşerken kontrol grubunda 14 olarak tespit edildi. Bu da istatistiksel olarak anlamlı idi. D-dimerlerimiz 995'ten 217'ye düşerken bu grupta 376'da. Ferritinimiz 794'ten 280'e düşerken kontrol grubunda 796'dan 314'e düşmüştü. 2-atisito kompleksimiz 5. gün kan tablosunda anlamlı derecede bizim için önemli olan parametrelerde düşme sağlamıştır. Klinik olarak da 2-atisito kompleksi değerlendirme için çalışmamızda devam ettik. Ateş şikayetleri 2-atisito kompleksi 64 hastada varken kontrol grubunda 69 hastanın ateş şikayeti vardı. Ateşin devam ettiği gün sayıları bu yanda yazanlar. 3.2 gün ortalama ateş 2-atisito kompleks grubuna devam ederken kontrol grubunda 7.4 gün gibi üst bir sayıda, kat bir sayıda etkinlik 2-atisilo kompleks tarafından gösterilmiş. Baş ağrısı olarak bakarsak yine benzer hasta gruplarında çalışılmış. 2.4 gün ve 3.2 gün gibi yine istatistiksel olarak anlamlı. Halsizlik 2-atisilo kompleks grubundan daha kısa sürede geçmiş. Tat koku kaybı, ek kas, eklem ağrıları da aynı şekilde 2-atisilo kompleksimiz daha etkin bulunmuş. O alan grup. PCR pozitiflik süresi burada 7.1 sayısı var. Çünkü Ulusal Sağlık Bakanlığı tarafından belirlenen COVID rehberinde sağlık çalışanların 7. günde test yapılabiliyordu. Bu 7. gündeki teste göre biz baz aldık ve PCR'larımız o yüzden ilk 7 gün yani çıkıyor. Kontrol grubunda ise 9 gün. Yani PCR pozitiflik sayısında da anlamlı bir düşüş sağlamıştır. Klinik çalışma sonrası biz bu çalışmayı kendi ilimizde ve bölgemizde ciddi anlamda herkese uyguladık. Ben kendim de evde böyle kendimi kötü hissettiğim zamanlarda kullandım. Zeynep hocamız COVID olduğu dönemde kullandı. Biz bu hastalarla ilgili valimiz, hani Erzurum valisine, Erzurum Belediye Başkanı'na, İl Sağlık Müdürü'ne ve birçok işte genel müdür seviyesinde iyiliğin önde gelen kişilere COVID olduğu zaman ciddi anlamda kullandık ve ciddi anlamda bununla ilgili geri dönüş sağladık. Kendileri de bize her seferinde bununla ilgili çok teşekkür ettiler. Özellikle bu tam ilk pozitif çıktığı andan itibaren ciddi bir kullanım indikasyonu doğdu. Bu konuyla ilgili ciddi, olumlu geri bildirimlerimiz oldu. Çalışmayı yapan arkadaşlarıma da bana destek olan teşekkür ederim.
Evet. Abdullah Hocam biz teşekkür ediyoruz. Gerçekten COVID dönemine damga vurmuş bir ilaçtı. Ben kendim COVID olduğumda kendime ve aileme kullandım. Birçok hastamızda da Abdullah'ın söylediği gibi içlerinde işte yakinen tanıdığımız insanlar vardı veya bir takım nedenlerle bu ilacı başladığımız insanlar vardı. Çok olumlu geri bildirimlerini aldık. Gerçekten buradaki bundan da önemli bir yayın çıktı. Buradaki tecrübemiz çok önemli. İnşallah ilaç sadece COVID'de değil, immünitenin güçlendirilmesini istediğimiz birçok durumda bize destek olacak diye düşünüyoruz. Ama COVID'in güncelliğinde ciddi mahiyette bir deneme imkanımız oldu, ciddi bir tecrübemiz oldu. Bu anlamda hem Almedico ilaca teşekkür ediyoruz. Bu geç saatte buradayız, hepimiz bu ilacı konuşuyoruz. Hem de Abdullah Hocama değerli katkılarından dolayı teşekkür ediyoruz. Sağ olunuz.
Soru veya katkısı olan yok herhalde. Tamamdır.
Soru veya katkı yoksa kapatabiliriz oturumu. Teşekkür ediyorum.
To the third day of the Scientific Session Congress, EPAT. On behalf of the EPAT Scientific Committee, I welcome you all. And it's my pleasure to introduce you Dr. Zeki Atlesi. He's an emergency physician from East Sussex Healthcare, NHS Trust. He'll be speaking about point-of-care ultrasound in shock. Over to you.
Good morning, everyone. Thank you, Sir Nat, for a nice introduction. It's a little bit early on a Saturday morning. I hope you are enjoying yourself as much as I do, as we do. I am delighted to be here, in my own home country and in Antalya, in a beautiful place. And I would like to thank, obviously, to our president, Professor Bashar Jander, and his team, to invite me here and to organizing such a beautiful event again after all this COVID issues and challenges. I have to start because we have got very little time. I've just been asked to talk about ultrasound, using ultrasound in basically undifferentiated shock. My name is Zeki Ateş, as you can see, and as my name suggests, I'm originally from Turkey, but I left Turkey about 40 years ago and went to Germany to study medicine and then worked there. And after that, I went to England to learn English, and then I stayed there because of basically creating a family. Thus, the place is Eastbourne District General Hospital. That's the place where I work. It is a smallish hospital, but we see around 300 patients a day. But we have got 3 hospitals under the umbrella of the East Sussex Healthcare Trust. Eastbourne is a place where basically this resort that we get lots of pensioners and elderly people in summer. For us, summer is a high season, not just winter. And the beachy head in Eastbourne is very famous for like a suicide spot. And that's the place where I live, is Brighton. It's on the south and on the coast, just very close by London. And it's called London by the Sea. What the objectives are about this ultrasound, using ultrasound in undifferentiated shock in emergency room or obviously in a critical care. And what we will do is just mainly talk about the protocols, and I will just give you highlights of the most used protocol or modules. And I would like to declare that I don't have any conflict of interest. I show you just the causes of shock. And this slide is a very busy slide, just showing basically there are different types of shocks. It's not always easy to find out what kind of shock is basically the case with your patient or with our patient. And sometimes this basically type of shocks can be together, coexisting, and that makes life much, much easier. As we know that what we used to do it in the past, someone hypertensive, we put an IV access in, 2 liters of IV fluids, and off you go. And we know now, obviously from the experience in the last few decades that it can be pretty lethal and harmful for our patients. This slide is, again, as in a very busy slide, but they're the shock protocols. There are lots of them there. Since 2000, there are lots of shock protocols that come out, and mostly used is now so-called rush protocol. And I'm just going to talk about rush and variation of it. And rush is basically standing for rapid ultrasound in shock and hypotension. That was created also by Scott Weingart, who's an American emergency physician. And the principle was mainly about 3 steps, talking about the pump meaning the heart, and the heart of everything. Yeah. And the tongue is meaning the chest cavity, abdomen, and pelvis, also including IVC as a basically a tool to have a look if the tank is full or empty. And also the pipes meaning the vessel, and the main vessel is obviously the aorta, maybe the cause of the shock of the patient, and looking for DVT. And I just want to show you just a variation of it. It's exactly the same thing. Maybe it may be confusing, like pipes and pump, tank, and pipes. There is a mnemonic, is so-called high map. That's exactly does the same thing. Heart, IVC, M for Morrison's pouch, meaning basically fast and looking into abdominal cavity, and pulmonary. Pulmonary meaning is the lung. On this is just mnemonic. There's a pulmonary with the lung, but is on the bottom. It actually should be on the top in the connection with heart, but in combination with just as a mnemonic, just basically to remember maybe high map. Basically, what do? We look at the heart at the center of everything if we assess a patient, because at the end is the heart, is the organ, is delivering oxygen and improving oxygenation and perfusion of the tissue. And therefore, it is one of the most important step of our using the shock ultrasound or the integrating ultrasound into patients with shock. Here we are looking for, obviously, mainly in the left the contractility of the left ventricle, just to see what the left ventricle does, the size of it. And then we are comparing the size of right ventricle with the left ventricle. And obviously we are looking for pericardial effusions, meaning maybe it could be a cardiac tamponade. And that's mainly the points we are interested in. What do you think about this heart? Is it doing okay? When you look at on the right-hand side is the left ventricle. Is it doing all right or not? It's basically in a poor function of left ventricle. What we are looking for is really, is it good or bad? Just especially when you start as a novice, just to focus on the basics, and then you just like, is it good or bad? That will give, basically, you can then integrate this information into your clinical judgment and find out what the problem is with the patient. What I do is always, when I do heart and lung together, basically I'm not going like, I'm going high map down and then lung at the end. No, just the heart and lung, and that goes along very nicely because it's so interconnected. Basically the heart, then while you are doing subcostal window, look at the IVC and come back to the chest while you are looking what the problem is with the lung. What we see is that was basically so-called B lines, very wet lung. There was a patient in acute heart failure with pulmonary edema. Here is a patient, that was a patient with cancer and big pericardial effusion. And as it says, PE, it doesn't mean pulmonary embolism, but it's just basically pericardial effusion, and that's in the clinical context, but this patient was absolutely shocked. There are other signs and other views, but because you have got this picture and then you've got a clinical picture in front of you, and then you make the judgment and do the good things about ultrasound. You can use it for your basically procedure, especially if you want a pericardiocentesis, and ultrasound is a beautiful gadget to help you with that too. And what we are looking at the heart is another thing, is the size of the right heart, looking for right heart strain. That was a patient that was 56 years old, and so that should play. I'll just show that one here. Then the second view, that's of the heart. As you can see, the left ventricle is in D shape, meaning that basically the right ventricle is dilated, is pushing the left ventricle, and that it just takes the shape of D, meaning that the pressure on the right heart is huge in acute settings. Obviously, then we put all these things together and thinking this patient has got massive PE. That patient we had we thrombolized because of the settings without the CT. After the heart, we just while we are doing the heart, we're just looking at the IVC, looking if is it full or empty. Anything between, again, we just take it cautiously, and if it is empty, obviously, then you can see the causes. It can be basically hypovolemic or distributive, and if it is big, and then that could be cardiogenic or obstructive, like a PE and tamponade. There are two pictures of IVC. On the one side is the empty, very small and collapsing fully, and the other one is large IVC. Again, then you put that in clinical context and with all your other imaging and investigations, and use it to your advantage to make the right decision. Morrison's pouch, meaning basically just doing the application of fast. What I call it basically, when you look at the chest and lung, just go to the next big cavity, which is the abdomen. When you look at the abdomen, just use your fast skills if you have got it, and then you start best on the right upper quadrant. Very useful also in non-trauma patient, and I have found it useful in the last few years. I saved at least probably 3 young ladies' lives because of ultrasound, because of the right decision and the right time and right treatment. And this is really crucial to have this skill. That's basically this lady. She was 31 years old. She came. She was treated for septic gastroenteritis, but she had actually ruptured ectopics. It took me less than 30 seconds what the problem was. The patient was already in the department for 4 hours, and she was in resus. And when I went, they called me because the patient was deteriorating, and ultrasound, Morrison's pouch, and then that was basically the video clip I had. And while I was talking to the patient, could you be pregnant? Put to my probe, and then I know what the problem was. And in 5 minutes, she was out of the department to the operating room. The pipes, or high map A, aorta, and obviously we're just looking for abdominal dissection of the aorta. That was in a patient. Unfortunately, he died because we delayed. We didn't recognize that he has got ruptured aortic aneurysm. And by the time I was involved, patient was passed away or arrested on CT. He was having CT KUB because we thought it was a flank pain. And there's a picture of aortic dissection. Because of the time, I will just go. If you advance in your ultrasound skills, obviously, then the pipes, you can look for DVT. What it helps is with, if you've got a patient is going to arrest and you think this is massive PE, and then if you find DVT, that gives you another tool that makes your decision easier to say, now I have to, I'm sure this is massive PE, patient is going to arrest, I'm going to thrombolize this patient. Okay, time is going on. There's pulmonary high map. The lung is always actually with the heart together, but is on this mnemonic is on the bottom. And this important thing is lung ultrasound is actually easy to learn for certain conditions and extremely useful. Echo can be complicated apart from the basic windows, but lung is for you the beautiful escape tool, because if the heart is not working, you will see lots of B lines, meaning wet lung, and you will see pneumothoraces, you will see pleural effusions, pneumonias, and so on. Time is running. This is a picture, video clips. One is normal where the pleural sliding, the other one, there is no sliding in a respiratory failure patient. And that's one picture again, pulmonary edema. Then we can look for effusions, and this is fully consolidated lung. Okay, I was just going to talk about the evidence, but I think my time is run away, now out. I'll just do a summary, and we just finished. I'll just do summary. There are these pictures you have
You can speak for 2 more minutes, no problem.
Huh?
You can speak for 2 more minutes.
Okay. There are other cases, but there is no time. As a 15 minutes, unfortunately, very short. There are lots of cases there. To summarize, ultrasound really will or can help you in managing critically ill patients, especially with undifferentiated shock. And what our President Professor Bashar Jandar also mentioned, I heard him a few times, making the right decision, right diagnosis, and right treatment in timely manner, because time is crucial if your patient is very sick. If you want to save this patient's life, you need to use all your clinical skills and everything available to you, but the ultrasound is extension of your clinical skills. It is unbelievable tool if you learn it. And if you practice, if you basically then become competent on it, it just will save lives. And especially if your patient is very sick and you need to make a right decision. I've got lots of cases where really ultrasound made definitely different, and I'm pretty sure in certain cases it may have ended up very badly. Any questions?
We'll take the questions at the end.
Yep.
We'll take the questions at the end.
Okay, yeah, that's no problem.
Yeah. Thank you.
Bye.
The next speaker, it's always a pleasure to introduce Errol. He's a mentor for many people, like Professor Bashar Chander is there. He will be speaking about the role of point-of-care ultrasound in resuscitation.
Yes. Good morning, everyone. I'm very glad to be here after so many years, and I feel that I am giving my first lecture, as I am giving my first lecture because of 2 years period, 2 years gap, and really I am happy to be with you. And also, I would like to thank my Professor Bashar Jandar to invite me and accept me in his team, and also Dr. Srinath Kumar for his great invitation. Thank you. Today's topic is the use of ultrasound in cardiopulmonary resuscitation, use of POCUS during CPR. It is very hot topic, but not like COVID. Really hot topic in the last 10 years. This is my lecture plan. I will talk about the milestones for POCUS in emergency department. And then after that, when and how you use ultrasound during CPR, arrest patients. And I will talk about the role of POCUS in cardiac arrest. A little bit, I will talk about the conflicting studies about the POCUS using CPR. And I will give some practical recommendations for your performance of POCUS during CPR. Really good recommendations. And I will try to sum up the lecture. As all we know that the ultrasound come to the emergency world during 1970s and emerged from the German trauma surgeons. Dr. Zeki knows better than me because he was there during this period. And they did ultrasound first in trauma patients. And after that, the trauma literature, ultrasound literature grows up, and there will be, there are a lot of guidelines, protocols now in emergency world, like ACIS protocols, like Dr. Zeki told, RUSH protocol, FOS protocol, FOCUS protocol. We have a lot of protocols. And after this bulk of literature, American Society of Echocardiography and also the American Academy of Emergency Medicine physicians sit around a table and release a statement about the use of ultrasound during CPR. And what did this statement say us? That first, you can use echocardiography or ultrasound as a non-echocardiographer or non-cardiac physician, I mean. But you should be well educated, well trained, and well experienced, and you should use ultrasound as an adjunct to the physical examination of the patient. So only you can use echocardiography as an adjunct to the physical examination. And after that time, in 2015, American Heart Association guidelines put the use of ultrasound during CPR in ACLS algorithms as Class 2B recommendations. And also the European guidelines embedded use of ultrasound in their guidelines. When we look at the literature, we are at the first rank. We are at the first rank who use ultrasound in their practices. 95% of emergency medicine specialists use ultrasound during CPR compared to the other specializations. And where we can do ultrasound during CPR and with which probe, according to literature again, the best view is the subcostal view, and best probe is the curvilinear probe. And at what time you should do ultrasound during CPR? You should do ultrasound during CPR during the pulse check periods or during the back valve mask ventilation of your patient. So what we have learned until now, use of subcostal view, use of subcostal view, and use of curved linear probe, and use of ultrasound during CPR during the pulse check of the patient, and also you can use it during back valve mask ventilation. Now, let's look at the cardiac arrest overall. When we look at the European literature, we see that approximately 30,000 of the patients in cardiac arrest patients, the initial rhythm was 20% of the time was a shockable rhythm. This is an UK study. So you see your arrested patients in either pulseless VT or ventricular fibrillation in 20% of the time. The rest, 80% of the cases were either asystole or pulseless electrical activity. Please keep this in your mind because I will come to this information 3 or 4 slides later. So we know that there is an increasing trend of non-shockable rhythms as initial rhythms presenting to our emergency departments, 80% and 20% as compared to the shockable rhythms. We can use our ultrasound during CPR as a diagnostic tool for pulse check, during the pulse check, or as a prognostic tool to differentiate the shockable rhythms with unshockable rhythms, and as a tool for decision making for stopping the CPR or not. So this is the tripod of use of ultrasound during cardiopulmonary resuscitation. When we look at the check of the pulse with your hands, we see that low sensitivity and low specificity. And we also see that high inter-provider variability. And according to the literature, accuracy is just reaches approximately 80%, and low sensitivity and even lower specificity for pulse check with our hands. And this is because it depends on your patient's body habitus, and also it depends on your experience. And if we look at the adult patients also, approximately 10% of the patients with no carotid pulse during the bypass were not recognized by the providers. So specificity is even lower in these patients. So what you can see during CPR with your echocardiography probe or with your ultrasound machine, either you can see a ventricular fibrillation like this image, or you can see a still heart, the heart not moving. This is called asystole. But you can see some QRS changes on ECG while your patient has no pulse and with no cardiac activity. In this case, your patient is called what? Pulseless electrical activity. Or your patient may have a flat line on ECG. In this case, you have no activity and you have a flat line on ECG. This is called true asystole. Or with arrest patient, you can see a cardiac activity like that. And also you can see on ECG there is some QRS changes, okay? But no pulse. And this is called pseudo-pulseless electrical activity. Pseudo-pulseless electrical activity. If you see a flat line on ECG in this patient with cardiac activity, in this time, this is called pseudo-asystole. This is very important. So you can see shockable rhythm. You can see a true asystole with no cardiac activity, with no ECG change, flat